Good afternoon, everyone. Welcome to our contraception webinar. I'm Becky Burbidge, the Deputy Chief Executive here at FPA. I'm here with Karin O'Sullivan, who's our clinical consultant, who is a sexual health nurse with many years' experience. We've got an absolute ton to get through this afternoon. We've got a bit of a packed session, so thank you for giving up your lunchtime to spend with us. We're going to try and get through everything as quickly as we can so that there's time for some questions at the end. And you will, of course, get the recording of the webinar at the end. We'll send that round so that you can refer back to it as and when you need to. So very quickly, today we're just going to cover, I'm going to briefly run through why we're doing a webinar on contraception. And then I'm going to hand over to Karin, who's going to talk to you about kind of some updates that we've made to FPA and Sexwise's contraception information recently over the last year or so. We're going to have a very quick look at some hot topics in contraception, namely fertility apps, which have never seem to be out in the media at the moment. We're going to look at some upcoming guidance that's coming out in the next couple of months as well. And we're going to have a very quick look at kind of some useful things that you can talk about in contraception appointments when you've got kind of very limited time, which I know you have. So just to quickly give you a bit of background, this webinar is part of our Sexwise programme, which, as you all hear, I hope you all know about, but we're a national programme designed to give you sort of help and resources in delivering sexual and reproductive health work and sort of promoting that to your patients. So I won't kind of talk anymore about that, but all the information you need is on the website at sexwise.org.uk/professionals. So why we're doing a webinar on contraception today, it's kind of one of the crucial elements of what Sexwise does. We provide kind of informed choice to people so that they can make a kind of a decision about what contraception they want to use. Good contraception services and information are absolutely crucial in kind of reproductive health and well-being. There's a Public Health England report that came out recently, which I'd absolutely recommend having a read of if you haven't already, about reproductive health. And they looked at contraception and a lot of other things as well. And they spoke to almost 7,000 women. I think, well, when I say spoke, they did a survey of almost 7,000 women, and they just found that kind of women feeling that they have control of their reproductive journeys is really important. And another piece of Public Health England research that came out recently looked at return on investment of investing in publicly funded contraception and found that every pound invested saves around £9 over 10 years. So, it's really crucial that we get investment in contraception services, and hopefully we can support you in a small way, just to deliver the services that you're delivering. Another thing I just wanted to highlight is that although it is a massive part of reproductive health, contraception isn't just a women's issue, but we do tend to talk about women a lot just because they're the ones who are most effective, spending a lot of their reproductive years trying not to get pregnant. But then on the flip side, there's that moment where you stop contraception and decide to get pregnant, and there's a really important link there with kind of preconception care and how we talk to women about kind of what they need to do to prepare for a healthy pregnancy, which is something that we also do on Sexwise. And we're really aware as well that kind of the effect that cuts are having on services around the country, and that reduced clinic services means that often patients are maybe going back to their GPs for contraceptive services when they might previously have gone to a clinic, or they're looking for kind of services elsewhere. Pharmacies have a really crucial role to play. I'm not sure how many pharmacists we've got on the webinar today, but your role in the community, I think, with contraceptive services is absolutely key, and other sexual health services as well. Having said that, the Public Health England report I mentioned earlier on reproductive health did highlight that GP practices are still women's preferred place to get contraception, although there was definitely also an appetite for getting things like the contraceptive pill from kind of pharmacists and online as well. So I think as we sort of go into the future, it's thinking about how we can best meet women's needs and get them the contraception that they want. And we also know that not all services can provide all methods of contraception for a wide variety of reasons. So it's really important that you're able to be able to signpost to up-to-date information about all the methods and know your kind of local routes of referral for the methods that you can't supply. So that's just a little bit of context. I'm going to hand over to Karin in a minute just to run through some information updates. So there's information on every method of contraception on the Sexwise website. We update this on a rolling basis and when new clinical guidance becomes available as well. So we use evidence-based guidance from the Faculty of Sexual and Reproductive Healthcare, from the World Health Organization, and from the National Institute of Health and Care Excellence to inform all our patient information. And the updates we're going to run through very quickly today are updates on the IUS, the contraceptive injection and sterilization, which we've made to our information recently, as well as a bit of a recap on post-pregnancy contraception and emergency contraception, both of which had guidance changes within the last sort of year to 18 months or so. So I hope you find this useful. To say, hopefully time for some questions at the end as well. But I'm now going to hand you over to Karin, who's going to talk to you about the IUS.
So I'm hoping that you'll be aware, but we just thought we'd run over the differences between the 4 different brands of IUS that are available now. They do contain different amounts of hormones. There's different sizes and work for either 3, 4 or 5 years, depending on the type of IUS that you choose or women choose. We don't cover them all by name in the patient information, but it's useful to be aware of the differences between them. So we have Mirena. I think most of you are familiar with Mirena, and the bits that I wanted to pick out on this is that it's licensed for contraception to treat heavy menstrual bleeding, and it is the only IUS that can be used for endometrial protection as part of hormone replacement therapy. Levocert works for 4 years. It was previously licensed for 3 years, but is now had the license extended for 4 years and may be extended to 5 years in the future. This is also licensed to treat heavy menstrual bleeding. We have Kylena, which is the newest IUS available in the UK. It works for contraception for 5 years and has a lower dose of the hormone than either the 4 or 5 year IUS. Has a smaller frame and insertion tube. And we have JDES. Again, I think you're familiar with JDES, which has a smaller amount of hormone in and also a smaller frame and insertion tube. So which one do you choose? I think it's really important to think about your patient, what's right for your patient in their particular circumstances. So is it somebody that would benefit from heavy menstrual bleeding control or as endometrial protection with hormone replacement therapy? So in the consultation, it's really important to think about all the intrauterine contraception can be used by younger women and women who haven't been pregnant. I think these are old myths that we've hopefully got away from now. Younger women are more likely to use user-dependent methods like pills and condoms, but is this because nobody offers them the long-acting reversible contraception, leaving them at risk of unintended pregnancies? So do let younger women know that the IUS is an option and signpost to contraception services for fitting if required. The smaller framed IUSs may be appropriate for women with a narrower cervical canal or a shorter uterine cavity, and they may also be associated with less pain and discomfort during insertion. But I think there's been lots of articles in the press, in the journal press about this, and the thing that comes out as being most effective is what we call the vocal local. So that's somebody that can support women during the insertion. So a bit of distraction, talking about other things. So do have a look at the journals for updated information about those. So when you're thinking about IUS as a method of contraception, do consider the pregnancy intentions. And something that's come out in reports more recently is that women often don't choose the long-acting reversible contraception because they think that that's it for the next 3, 4 or 5 years. So do point out that any long-acting reversible method can be stopped earlier than the licensed use. So it doesn't have to stay in for 3, 4 or 5 years. Women can have methods removed sooner than that. Think about their relationship status. Do they only want to use contraception when they have sex? So again, women will want or choose different methods of contraception depending on lots of other factors. Are there worries about use of hormonal contraception? So do talk about the benefits and risks of hormonal contraception. So sometimes women are just not aware of the benefits of hormonal contraception, and I think it's really important that we talk about the good as well as the perhaps not so good. And it's always important to talk about some of the risk factors with the intrauterine methods, and something that women again get worried about is ectopic pregnancy. So I think it's important that although we do mention that it is a risk, when we're counselling women, it's really important to say that because there is a very low risk of pregnancy, there is a very, very low risk of that pregnancy will be an ectopic pregnancy, and not to word it the other way round. Let's move on to injections. Injections are easily given at surgeries and other locations, and I think Ciana Press is something that hopefully you'll all be aware of now. So both Depo-Provera and Ciana Press can be given every 13 weeks. So that multiplies up really nicely to be 4 times a year. Depo-Provera is licensed for 12 weeks and 5 days, but it's been very common for us to give Depo-Provera at 13 weeks. Both Depo-Provera and Ciana Press work for 14 weeks. So you've still got that 1 week leeway to remember, for women to remember to come to clinic. We've also got the 8-week Neristerat, but it's not commonly used. I certainly haven't used it in the recent past. So unlike other long-acting methods, it is possible to, for the injection to be less effective, which is why when we're coming on to talk about tiered effectiveness rates, that people may forget to come back for their next injection. So there is some apps where people can be sent reminders to come, but it is important that we think about injections being less effective than the other methods of long-acting reversible contraception because people don't always come back at the right time. So when we're looking at the typical effectiveness rates, we're looking at around 94% rather than more than 99%. And this means that that 6 in 100 users will become pregnant in a year. Really important thing about Ciana Press is that it can be self-injected, and this is a cost and time-saving thing for both services and patients. They can be given a year's supply rather than having to return for an appointment every 13 weeks or 3 months. So again, people can get reminders to give their next injection to themselves, and teaching materials are available so that we can work with patients to teach that. So it saves on clinic time. So it's something we really should be discussing with medicines management committees. I think that's a really valuable thing that we can do. So our leaflet on injections has been updated recently. So this is what it looks like. I hope you're all familiar with it. Injections can be used up until age 50, sometimes slightly beyond, but we should be talking to women about risks and benefits, etc. And it's important that we look at, again, busting some of those myths. We don't need to do bone density scans or DEXA scans for women, but we should talk to them about the risks associated with possible osteoporosis. And that includes talking to them about things like diet. How is your diet? Do you have lots of calcium, dairy products, etc., good for bones? And also looking at other risk factors for osteoporosis. So do women smoke? Are they immobile, very slim? Are they taking any medication that would cause problems such as long-term steroids? But it's a risk assessment rather than actually saying to women you can't use Depo. We need to look at everybody as a whole person rather than stopping people from using things which are very effective. And under 18s, so the query about under 18s is about have they developed their bone mineral density if we're going to delay or reduce it for a short while they're using the injection. So the advice is that under 18s can use the injection if other methods are unacceptable, but it wouldn't be our first choice. So again, it's about looking at the person in front of you, working with them, working out what's important or not important. Pregnancy intentions. This is the one method of contraception that's not immediately reversible. So return of fertility can be delayed. So if I had somebody coming in to see me that wanted to plan a pregnancy next year, we would be talking about a different method of contraception rather than the contraceptive injection. So it's something to just be aware of. Another recent update, sterilization. We have updated the FPA sterilization leaflet. And the main change was really that hysteroscopic sterilization, or eSure, is no longer available. This was withdrawn by the manufacturer, who stated that it was due to a decline in demand. But women with eSure can be reassured that it's safe. So it's not been withdrawn because of safety issues, but just due to a decline in the demand. Sterilisation services in the NHS are being cut in many areas, and this does reduce choice for men. So it's really important to ensure that women and men know about long-acting reversible options, including where to access these locally. Sterilisation is less in demand now due to the reversible contraception that we have got. But again, women and men sometimes have difficulty accessing the services or the information. So do have a look at the new leaflet when you get a chance. Post-pregnancy contraception. This was a huge change. The updated guidance released in 2017 followed the 2016 changes to the UK MEC, medical eligibility criteria. We're all familiar that contraception is needed from day 21 to ensure protection from ovulation, which earliest known ovulations usually can be from day 28. So you've got to allow for that week for your contraception to be effective, to prevent sperm survival, meeting egg. But most methods can now be started straight after the birth. So this is quite a big change that some of us have had difficulty getting our heads around. So I hope you're all familiar with that now. We do still get some queries on the FPA Sexwise question line about, my doctor or nurse has said I can't start something, your leaflet says I can. So please look at our leaflets. But the IUD and the IUS can be fitted within 48 hours of birth or from 4 weeks after birth. So there's a lot of research going around about the acceptability of doing this, and women do find it acceptable. Expulsion rates can be slightly higher, but the benefits of protecting from pregnancy straight away are very acceptable to women and clinicians. So do have a look at that. Find out in your local area if that's available in your hospitals. Combined hormonal contraception, this is the other big change. If you're breastfeeding, we used to say that you couldn't use this for 6 months after birth. can now be started from 6 weeks after birth and does not affect milk production. So combined hormonal contraception can be started from 3 weeks if not breastfeeding, or 6 weeks if you are breastfeeding. Obviously, women still need to be assessed for medical eligibility, so some of the VTE risks are higher immediately post-birth. So again, look at the UK medical eligibility criteria to check those if you're not sure. Emergency contraception, the guidelines were updated in 2017. So again, have a look at those to familiarise yourself if you're not already. But this is the main reminder is that hormonal contraception should be delayed for 5 days after taking UPA, as it may stop the UPA from delaying the ovulation as effectively. So the faculty guidelines on quick starting hormonal contraception are really useful to look at. So again, that information is out there. Please do have a look to update yourself. One of the main changes is the way that emergency contraception has been ordered in leaflets. So IUD is the most effective. The UK MEC changed the order that contraception was written about, and we've done the same in our leaflets. So the IUD is the most effective at preventing pregnancy. If you can't fit that yourself, then know where to signpost to. Emergency pills are unlikely to be effective after ovulation has taken place. So there's lots of guidance on this. There's some really useful algorithms in the faculty guidance. So it's really useful to have those 2 pages on how to choose which method and which method is most suitable for women. So again, I would have those as one of your desktop favourites to have a look to help with that decision making. So, hot topics. There's been a lot of press about fertility and period tracker apps. So it's something that you may be asked about. It kind of has a background in the wider context of worries about hormones and the appeal of natural options. But it's really important to note that there's no system to regulate and evaluate apps that are not currently covered by faculty or NICE guidance. Most apps are not designed to be used to prevent pregnancy. If an app is only tracking menstrual cycle dates and estimating an ovulation day based on this, it's not reliable and should not be used to help prevent pregnancy. Other apps will track temperature readings as well as dates, and some may encourage tracking of cervical secretions. These are a more reliable way to predict ovulation, but still user dependent, and various factors can make this less effective. So actively listen to women's concerns. Some things that crop up frequently is that women don't feel that their concerns, for example, about hormones or side effects are heard. So again, I'm back to discussing the benefits of some of the hormonal methods of contraception, the protection from cancer of the ovary, womb and colon, the benefits of reducing painful heavy periods. So talk about some of the benefits and discuss alternative non-hormonal options, including the highly effective IUD. So when we're thinking about fertility and pregnancy period tracker apps, do discuss pregnancy intentions. Are women wanting to space or limit their family, or is pregnancy a definite no, really don't want to have a pregnancy at this moment in my life? So apps are based on fertility awareness methods, and typical failure rates can be high, but the more effective way of using fertility awareness is with support from a trained teacher to actually look at what some of the differences are and how to manage those. It's also important to discuss the need to avoid sex or use condoms on identified fertile days. So do signpost again, have a look at the FPA Fertility Awareness Leaflet, and Fertility UK has the website has lots of evidence-based information in there, and also details on how to contact your local fertility awareness teachers. So what's coming up? We've got new guidance from the faculty on combined hormonal contraception and tailored regimes. There was a paper published by Professor John Guillebeau last year looking at taking the combined pill as a 21/7 regime is outdated, and suggesting that the 7-day pill-free interval is one of the main causes of pill failure, because if women start to take their next pack of contraception late, what they're doing is extending that 7-day pill-free interval. Lots of evidence shows that it's safe to take the monophasic combined pill for extended periods or continuously, and this is as effective as taking it 21/7. There is no medical need to have a withdrawal bleed when using the combined pill, patch or ring, and this is something that I've talked to women about for a long time. You know, why do we want a period every month? Let's not. Let's save money on sanitary protection and get rid of all the problems that women will have during the pill-free interval or the hormone-free interval. So faculty guidance has previously covered tailor regimes, but updated guidance, which is due out in October, has more information on the evidence of safety and effectiveness. And we will be producing, updating our patient information shortly after that to help you communicate the options to patients. So some of examples of alternative regimes, which I'm sure some of you will be already using, is shortening the hormone-free interval to 4 days instead of 7. I think lots of us are using the extended use tricycling, taking 3 packs or 9 patches or 3 rings with no hormone-free interval, and then having a 4 or a 7-day break. And then extended use or flexible use with a short or regular hormone-free interval, so continually using it until breakthrough bleeding happens, and then have a hormone-free interval for 4 or 7 days. So watch out for the guidance that's coming out, and we will look at talking about that in more detail in the future. Right, we're really short of time, so tips for a 10-minute appointment, look at the info, effectiveness rates, etc. Look at the tiered model on effectiveness use. Point out that LARC, just because it works for years, doesn't mean it can't be stopped sooner, and look at other factors that are important. Signpost to Sexwise, my contraception tool, and we've Sexwise cards to give out for you if you want them. Listen, make sure the patient knows what to do if there's any concerns, take side effects seriously. Be aware of consent and safeguarding. We've got Sexual Health Week coming up very shortly, so watch out for that. We don't have time to answer questions, but very happy for you to send us some questions in. We will answer later.
Hello again, Karen's just handed back to Becky now. We might very quickly have time for sort of 1 or 2 questions if we run over a little bit. So let's see if we can just make the questions option appear for you. Oh, bear with me a second. No, sorry, I don't think that's going to work. So there should have been questions now, but if you would like to email us your questions through to sexwise@fpa.org.uk, we will be very happy to answer kind of anything that's cropped up during the webinar. Apologies for that, we're having a few technical issues at this side, which means that the option for you to kind of input your questions here and for us to answer them isn't coming up. So I'm very sorry about that. So yeah, do get in touch. Again, it's sexwise@fpa.org.uk, and the contact details are also on the website. So just to let you know as well that there are sources of information listed at the end of the webinar. There'll be you'll be able to kind of check all the references and things if you need to when we send the send this recording round, which should be in the next week or so. And just to let you know as well, our next webinar, hopefully without technical issues, where you will be able to ask us questions and get the answers, is running on Thursday. Again, it's another lunch and learn, so it kicks off at 1 p.m. And it's on pleasure, pain and problems. So really looking at wider sexual well-being and how you can kind of help your patients have a more fulfilling sex life and causes of kind of common problems and concerns, and what you can do if people come to you with those. We've also got an FPA training course on contraception, which is a 2-day course. It's a comprehensive introduction to contraception, and the next dates on that are in September and March. If you're interested in coming along to that, please do sign up for our Sexwise updates if you haven't done already. Again, the details are on the website. I've already mentioned that we'll obviously send you around the recording. You also get a certificate of attendance if you've attended for more than half of this session, and we will email those around as well. At the end, I think when I close the webinar in a moment, you'll just get an option to be able to kind of rate it and pop in some feedback if you want to. So please do that so that we can take that into consideration and improve in the future. Preferably on the content, please, and not the technical issues, although I do apologise for the technical issues. I hope that it's been useful for you, and we really appreciate you giving up your lunchtime to attend. So thank you very, very much indeed, and we hope to see you at the next webinar. Thank you.